Hey, good morning, guys. Good morning, class. This is Mr. Alberto Verdad. It's 2 a.m. in the morning. Actually, it's 2:03 in the morning. I'm still awake, and I just decided to come up with another video lecture related to disorders of the endocrine system. This time, I want to talk about goiter and disorders of the parathyroid gland, and we might have I'm not really sure if we totally discussed goiter and hyper and hypoparathyroidism in our previous discussions, but if not, then hopefully this video will will give you a supplement materials to study for your exam on Tuesday, and hopefully you can use this for your preparation for the HESI exam at the end of the course, and of course for your NCLEX preparation as well. So let's talk about goiter and what do we know about goiter. Um, I remember I mentioned in the past that goiter, or in a previous discussion, I mentioned that goiter is an enlargement of the thyroid gland, but I've seen a lot of books saying that this is actually a hypertrophy of the thyroid gland. Well, it's not hypertrophy, and that definition is not entirely accurate because the enlargement of the thyroid gland in the case of goiter is more of hyperplasia of the thyroid gland, and the hyperplasia of the thyroid gland in goiter is associated with an increased need to produce T3 and T4. The main problem in goiter is not so much about hypo or hyperthyroidism. In fact, goiter is not caused by inflammation or neoplasm or a tumor, and it's not initially associated with the hyperthyroidism or hypothyroidism, but it's the lack of iodine in the patient's diet or in the patient's system. So the lack of iodine in the diet of the patient can actually lead to decreased production of T3 and T4. So, because iodine is a raw material utilized by our body, particularly of the thyroid gland, in order to produce T3 and T4, they need that iodine raw material. And so, if the patient is not eating foods containing iodine, then the thyroid gland won't be able to secrete or release T3 and T4. And what will happen is the goiter will respond by increasing the number of the thyroid cells that can produce T3 and T4, because the assumption is the more cells that can produce T3 and T4, then the more T3 and T4 will be released or will be secreted. Um, so that is a compensatory mechanism of the body, and uh, the compensatory mechanism is triggered by, again, a negative biofeedback mechanism. However, the problem is the thyroid doesn't realize that the problem is not the number of cells that can produce T3 and T4. The problem is the lack of raw material that can be utilized to produce T3 and T4, which is, of course, iodine. Um, I think I have mentioned in our previous discussions that here in the United States it's almost unknown. Um, or what I'm trying to say is that I've been living here in the United States for about 15, almost 16 years now, and I still haven't seen or haven't heard of any patient with goiter. So what I'm trying to say is that here in the United States, it's almost impossible for us to see a patient with goiter because we have basically access to seafood all the time. We have iodized salt available in every grocery stores, and people are using those iodized salts. In fact, we have different types of salts here in the United States. We have iodized salts, we have non-iodized salts, we have rock salts, we have Himalayan salts, we have mixed salts, we have artificial salts or salt substitutes. We even have salts that we're just using for creating ice cream. So it is almost unknown. Um, it is almost unknown disorder here in the United States. Of course, if you go outside the United States, like in third world countries, especially people who are living in far-flung areas like in the mountains, and their main source of food are root crops, then yes, you can probably, or you will probably see patients developing goiter. There are two general classifications of goiter. One is called an endemic type of goiter, and the other one is sporadic. What's the difference between endemic and sporadic type of goiter? In endemic type of goiter, the goiter is actually caused by a lack of iodine in the diet, leading to, of course, inadequate secretion of thyroid hormone, particularly T4. Um, inadequate synthesis will mean inadequate release of thyroid hormone. In sporadic type of goiter, usually the hyperplasia of the thyroid gland is triggered by ingestion of some goitrogens, such as goitrogenic foods or goitrogenic drugs. It occurs randomly, and usually people who ingested goitrogenic food or goitrogenic drugs in large amounts are those that will be affected by sporadic type. Um, you might be asking, what are the foods that are considered goitrogens or goitrogenic foods? These are cabbages, soybeans, peanuts. Um, Peaches are considered goitrogenic foods as well. Peas, strawberries, I love strawberries. Spinach, radishes are considered goitrogenic foods. For drugs, you have propylthiouracil. It can decrease the production of T4, iodides, phenylbutazone, and even acetylsalicylic acid or uraspin and lithium are considered goitrogenic drugs. So people who are taking these medications are susceptible to develop hyperplasia of the thyroid gland, simply because these medications can potentially decrease the production of T4. And same thing with your goitrogenic foods. If you consume these goitrogenic foods in large amounts, then there is a possibility that it can trigger hyperplasia of the thyroid gland. This is an old picture of a patient with enlarged thyroid or toxic goiter because of the mere size of the thyroid gland. And it's amazing that this person um, survived, obviously, um, despite of the fact that she had this big thyroid in her neck. And if you look at this, you have to remember that the thyroid gland hugs the trachea, and it can also affect the esophagus because there's only a thin, membrane separating the esophagus from that of the trachea, and with the with the thyroid gland as big as this, then it can actually partially or completely obstruct the trachea that can lead to shortness of breath. And it's amazing that when this picture was taken and with the size of the thyroid gland like that, she was still alive. But obviously, this was actually an old picture, and I don't know if I have seen. Actually, I have not seen a patient with a big goiter like this in my 30 years of nursing experience. Anyway, so how do we manage goiter or toxic goiter like this? You have to remember that the management is geared towards reducing the hyperplasia of the thyroid gland, and there are certain medications that can help reduce hyperplasia of the thyroid gland. Simply, you want to decrease the need to secrete more T3 and T4, and so medications like levothyroxine will help prevent the hyperplasia of the thyroid gland because you're providing the patient exogenous supply of T4 already. Same thing with liothyronine or brand name Cytomal, because that's a synthetic T3. And a Lugol solution. A Lugol solution is basically iodine solution. And if you provide that to the patient will or it will help again the production of T4, thus reducing hyperplasia of the thyroid gland. Um, so um, most of the management for goiter is obviously um, supportive management and symptomatic treatment. Whatever the symptom is, then we will manage and we will support the patient. The patient is having shortness of breath, then of course we will help the patient with breathing, positioning, oxygen, but a toxic goiter as big as this, or even the smallest type of goiter, a lot of times it will end up with surgical removal of the thyroid gland. And if the patient had will go for thyroidectomy, then of course we will manage the patient pre and post surgery. Um, and there are a lot of things that we need to give to the patient as health teachings, like for example, monitoring the calcium level, monitoring the patient for signs and symptoms of hypocalcemia after thyroid surgery, and probably the need to take medications for life if if the patient will have a total thyroidectomy. You have to remember also that the parathyroid gland or the parathyroid thyroid glands are located or situated behind the thyroid gland. So any removal of the thyroid gland will definitely affect the functions of the parathyroid glands as well. And that can lead to hypocalcemia that may have fatal complications, not just tetany, not just positive shibastic signs or trousseau, but it can lead to seizures and it can also lead to fatal cardiac dysrhythmias. Okay, so moving forward, let's talk about disorders of the parathyroid gland. First up, hyperparathyroidism. What is hyperparathyroidism and what are the symptoms associated with hyperparathyroidism? In order to understand hyperparathyroidism, we have to understand the functions of the parathyroid gland. The parathyroid gland are small glands located behind the thyroid gland. Some people will have four small glands or four small parathyroid glands. Some people will have six parathyroid glands. And the main function of the parathyroid gland is to release or secrete a hormone called parathormone or PTH or parathyroid hormone. The parathyroid hormone is responsible for keeping the normal amount of calcium in the blood. So there is a check and balance relationship between the thyroid hormone calcitonin and the parathyroid gland hormone parathormone. If the function of calcitonin is to deposit calcium from the blood to the bone. Uh, However, the parathyroid gland or the parathormone rather um, ensures that the calcium level in the blood will remain normal so that if there is a decrease in the calcium level in the blood due to too much secretion of calcitonin, the parathyroid gland will release parathyroid hormone or the parathormone to mobilize some calcium from the bones and bring it back to the blood to avoid complications or to avoid hypocalcemia. However, if the parathyroid hormone is released in massive amounts due to hyperparathyroidism, then it can lead to several complications like too much calcium level in the blood, and hypercalcemia can cause cardiac dysrhythmias as well. Not to mention that if you mobilize calcium from the bones and bring those calcium to the blood, it's like a double whammy. You will have too much calcium in the blood, but your bones will become weak and brittle, and you will have bone demineralization that can lead to pathologic fracture and even osteoporosis, of course. Aside from that, remember that this calcium, if you have too much calcium in the blood, this calcium can actually form crystals like calcium oxalates and calcium phosphates that can lead to development of kidney stones. So stone formation is common in hyperparathyroidism. The patient will be susceptible to stress fractures and osteoporosis, not to mention the fact that increased calcium level may have a deleterious effect in the electrical conduction of the heart that can lead to cardiac dysrhythmias. Other symptoms will include apathy. Patient will have fatigue, muscular weakness, again related to electrolyte imbalances. The patient will have constipation due to increased calcium level in the blood, nausea, vomiting, hypertension, and of course cardiac dysrhythmias, which could could be fatal, especially if it leads to ventricular tachycardia and ventricular fibrillation. As far as incidence is concerned, women are affected more than men, actually, 2 to 4 times more common in women compared to men, and the common age is between 60 to 70 years old, and there are about 25 cases per 100,000 people affected with hyperparathyroidism. Um, how do we manage this hyperparathyroidism? If there's too much secretion of the parathyroid hormone and there's too much calcium mobilization from the bones to the blood, leading to hypercalcemia, then the number one thing that you don't want to happen is for the patient to become dehydrated. Because if the patient becomes dehydrated, then those calcium in the blood can easily transform into calcium crystals like calcium oxalates and calcium phosphates. So the goal of management is to make sure that the patient will be hydrated uh, fully, like increase fluid intake of the patient, maybe 3,000 mils per day, as long as it's not contraindicated, obviously, like for people with congestive heart failure or pulmonary congestion, then you may want to be careful with that and follow the doctor's order. But generally speaking, hydration is a must for a patient with hyperparathyroidism. Of course, to prevent renal calculi. um, the use of acidifying agent is necessary as well. In fact, it is important because if the patient is susceptible to development of renal calculi, then you don't want the patient to develop kidney infections associated with those renal stones or renal calculi. So acidifying agents like cranberry juice, um, acai berry, those are really important acidifying agents to prevent urinary tract infections. Prune juice can be used as stool softener because of this increased calcium level, the patient will be susceptible for constipation. So prune juice can help, regulate the bowel movement. Stool softener, and again, increasing the fluid intake will help prevent those complications. Encourage mobility of the patient or encourage ambulation, because if encourage ambulation, then again it will help in in maintaining the good bowel movement of the patient, and it encourages the digestive process to maintain its normal peristaltic movement. No thiazide diuretics. Again, like I said, patient needs to have an increased fluid intake, but no thiazide diuretics. Let's think about that for a while. Why no thiazide diuretics? Um, if you give any type of diuretics, or if the doctor prescribe any type of the thiazide diuretics like hydrochlorothiazide or any type of diuretics that would cause excretion of potassium or potassium wasting diuretics, you have to understand that most potassium wasting diuretics, particularly thiazides and hydrochlorothiazides, they actually reabsorb calcium, and so they can eliminate potassium from the urine, but they will reabsorb calcium. So in the case of hyperparathyroidism, you don't want to give thiazide diuretics to the patient because you're not just eliminating potassium from the patient's system, but you're also reabsorbing calcium, and the patient already has a very high calcium level in the blood. So that will cause a compounding effect, and that can put the patient more into complications like cardiac dysrhythmias, constipation, and hypertension. So how do we manage hyperparathyroidism? Well, aside from all of this nursing management, usually the management will involve removal of those parathyroid gland or parathyroidectomy. However, there are some complications of that because if you remove the parathyroid gland, then it can actually shift to something else. It can actually lead to hypocalcemia if there is nothing that will check the functions of your calcitonin. So it has to be monitored. So the serum calcium level of the patient must be monitored, carefully, because hyperparathyroidism can lead to hypercalcemic crisis or too much calcium level in the blood. Any serum calcium level greater than 13 milligram per deciliter has to be reported. Or it's a panic value, and that can lead to what we call hypercalcemic crisis. So management will be rapid rehydration, normal saline, to maintain a urine output of 100 to 150 mils per hour, and then calcitonin will be given or will be administered to the patient as well. And calcitonin will help move those calcium back from the blood to the bones, increasing the bone density, strengthening the bones, and decreasing the calcium level in the blood, and at the same time, preventing formation of renal calculi or calcium crystals. Okay, so hyperparathyroidism, this is a caricature of a patient with hyperparathyroidism. A lot of times it's triggered by some adenoma or a tumor or some kind of malignancy of the parathyroid gland. Patient will have high blood pressure, again, bone demineralization. It can actually lead to depression and psychosis, kidney stones, stomach ulcers, and even pancreatitis. Um, so the calcium balance, I'm not gonna talk much about this. Just want you to know that if the calcium level in the blood exceeds 13 milligrams per deciliter, and that's something that you may want to remember, then the patient can go into hypercalcemic crisis, and the patient needs to be treated aggressively, like increasing the fluid intake and giving those calcitonin medications. Let's flip the coin, and what if I don't have adequate secretion of the parathyroid hormone, or parathormone? It can lead to a condition called hypoparathyroidism, and in hypoparathyroidism, the patient will have a very low level of calcium in the blood because there is nothing that will check the action or the function of calcitonin mobilizing or moving calcium from the blood to the bones. Because there is a decreased calcium level, phosphate level will increase in the blood. Patient can develop neuromuscular irritability and tetanic contraction because of decreased calcium level. So the patient will have positive Shibasek sign, positive Trousseau sign associated with hypocalcemia. Patient will have spasms, numbness, and I hope you still remember how to elicit Trousseau sign and Chebostack sign. Chebostack is involuntary muscular contraction of the facial muscle. If you tap the cheekbone area of the patient, um, and positive Chebostack sign is highly suggestive of hypocalcemia. Same thing with Trousseau. Trousseau will be elicited by getting the blood pressure of the patient and adding the systolic blood pressure from that of the diastolic blood pressure divided by 2, and then you will reinflate the blood pressure cuff again to that particular number. So let's say 120 plus 80, then you have 200 divided by 2. You will have to reinflate the blood pressure cuff to 100 millimeters of mercury. And if the patient has hypocalcemia, then the patient will have involuntary flexion of the wrist, and it will cause numbness and tingling sensation in the fingers and hand of the patient, highly suggestive of hypocalcemia again. And that's what we call Trousseau sign. For nursing management, a patient with hypoparathyroidism, you want to give a high calcium diet in order to replenish or supply additional calcium for the patient, but you don't want phosphorus in the diet, and because of that, no dairy products. Spinach is recommended for the patient. Dairy, because most of dairy products, although they have high calcium, they also have high phosphorus level. So you want to make sure that the patient will be given high calcium diet, but you don't want the phosphorus in most dairy products, because the patient will already have an increased phosphate level. So it's better to give patient calcium supplements, and most calcium supplements, of course, are fortified with vitamin D, because you won't be able to absorb calcium, obviously, without vitamin D, particularly vitamin D3 or um, vitamin D1 is calciferol. Vitamin D3 is calcitriol. So most calcium supplements will have to be given along with vitamin D3 preparations like calcitriol to ensure proper absorptions of those calcium. The normal phosphate level in the blood is between 2.4 to 4.1 milligram per deciliter, and the normal calcium level is between 8.5 to 10.5 milligram per deciliter. And if you remember, any calcium level higher than 13 milligram per deciliter is already considered hypercalcemic crisis. In the case of hyperparathyroidism, it can lead to an elevated calcium level due to that mobilization of calcium from the bones to the blood, secondary to too much secretion of parathyroid hormone. However, in hypoparathyroidism, the patient will be susceptible to hypocalcemia because of too little secretion of the parathyroid hormone. You have to remember also that calcium is not just a mineral. Calcium is also an electrolyte. So in this case, if you see calcium expressed in milligram per deciliter, then it means that we're talking about the mineral calcium. If calcium is expressed in milliequivalent per liter, then that calcium is treated as an electrolyte. Aside from being an electrolyte and being a mineral, remember that calcium participates in the clotting cascade as well. And in fact, calcium is clotting factor number 5 and or number 4. And any form of hypocalcemia can lead to a problem in a clotting cascade as well. Um, so the patient with hypoparathyroidism and with hypocalcemia will be susceptible for bleeding. So all bleeding precaution has to be observed, like those um, the toothbrushes with the sub-bristle toothbrush, watching all the orifices, observing for signs and symptoms of bleeding. If you need to give intramuscular injection to the patient, use the smallest needle possible. Those IV has to be checked every now and then. Check the urine of the patient for possible bleeding. Check the stool of the patient for possible bleeding as well. And again, observe all the orifices of the patient for any form of bleeding. I have a couple of questions here for you that might help you with your NCLEX preparation and your preparation for Tuesday's exam, like this one here. A client is hospitalized for hypoparathyroidism. The nurse assesses the client and notes positive trousseau and Chebostek sign, which are indicative of rich electrolyte imbalances. And I thought this is a very easy question. Obviously, we're talking about trousseau and Chebostek. Those are classic sign of hypocalcemia. So if your answer is hypocalcemia, then you are correct. It has nothing to do with sodium and potassium. It will not affect potassium. And trousseau and Chebostek signs is not indicative of hypokalemia nor hypermagnesemia, but rather hypocalcemia. Here's another one. During a thyroidectomy, a client's parathyroid glands were inadvertently removed. Which of the following lab tests must be monitored very closely? So again, if you remove the parathyroid gland accidentally during a thyroidectomy, the problem will be related to the mobilization of calcium, or the control of calcium um, from the blood to the bones, or from the bones to the blood. So it will always be the serum calcium level that you want to monitor if the parathyroid glands were accidentally removed during surgery. Um, I guess that's all I have for you today related to this thyroid and parathyroid gland, and of course the goiter. And if you have any question, feel free to send me an email, and I will respond to it as quickly as possible. And I'll see you Tuesday for your message too. Thank you very much, and good night.